Good morning to the distinguished faculty, colleagues, and delegates. It gives us great pleasure to welcome you all to the second day of our conference. Yesterday, we witnessed insightful discussions, cutting edge research presentations, and thought provoking exchanges that set the tone for an enriching academic journey. Today, we continue with the same spirit of scientific curiosity and collaboration. The sessions ahead promise to cover a wide spectrum from advances in clinical practice to innovations in research that will shape the future of medicine. This is also an opportunity to share experiences, challenge ideas, and strengthen the network that binds us as a medical community. With that, let us begin the proceedings of day 2.
So for this first session, I would like to invite our moderators, Dr. Amrish Sahni, Dr. Amit Jindal, Dr. Subrat Roll, Dr. Abhishek Dio, Dr. Kuldeep Solanki, and the chairpersons to chair the session, Dr. Yogesh Sanvaria, Dr. J.C. Vich, Dr. Rahul Gupta, Dr. Sunil Jain, Dr. Rakesh Jha, and our first speaker will be Dr. Virendra Singh.
Good morning. I am thankful to the organizers of this conference for giving me this opportunity. In the next 10 minutes, I will be speaking on the pitfalls and utility of albumin on domiciliary basis in cirrhosis. Cirrhosis leads to decrease in the serum albumin. It causes the increased risk of the death in patients with the cirrhosis and infections. Albumin undergoes structural and the functional changes as the liver damage progresses, affecting its antioxidant, immunomodulatory, oncotic, and endothelial stabilizing properties. This is the pathophysiology of complications of cirrhosis and the protective properties of albumin. It protects liver by the oncotic properties and the non-oncotic properties. The albumin has been used in patients with the cirrhosis, and its validated uses, especially in 3 situations: in PICD, in SBP, in AKI. New options in decompensated cirrhosis and acute on chronic liver disease. The debatable use in some, the long-term use in decompensated patients, especially the ANSWER and the MATCH trial and the pilot Preciosa studies. Then the patients hospitalized due to decompensation, the attire study, infections other than SBP, hyponatremia, and hepatic encephalopathy. In PICD, there is a arteriolar vasodilatation which leads to the decreased effective arterial blood volume. There is a 50% increase in the PRA with a final value greater than 4 nanogram per ml on day 5 or 6 post paracentesis. Albumin, if given in the doses of 6 to 8 grams per liter of the fluid removed, prevents the development of PICD. See, this is a comparison of the various products, the albumin, dextran 40, and the plasma volume expansion, especially after the PICD, after the large volume paracentesis, and the PICD even occurs after the albumin infusion, and it occurs in about 15% patients. See, since there is a splanchnic vasodilatation, the terlipressin has been used to combat the development of PICD, and this was a landmark study by Maru, published in Gut in 2002, in which he compared the role of terlipressin and the albumin, and he showed that the terlipressin was equally effective in preventing PICD. We also conducted a similar study and showed that both terlipressin and albumin prevented the development of PICD. This was long back when the trolley was introduced in our country, and it was very costly. So I tried the NORAD. NORAD also, the compared the two groups, the NORAD and the albumin group, and NORAD also was effective in preventing PICD, but at a lower cost. Then these were the injectables. So I switched over to the midodrine, and I tried to use midodrine for the prevention of PICD and gave it for 3 days, and this was also effective in preventing development of PICD. This was compared with the albumin. This was a meta-analysis done by the Bernardi, in which he compared the vasopressors and the albumin, and showed that the vasopressors are not as effective as albumin in preventing PICD. Another very common use of the albumin is the AKI. This is the proposed algorithm for the management of AKI. Here, if it is AKI stage 1, we usually don't use the albumin. We follow these patients. If it is stage 2 or 3, in that case, the albumin is given along with the terlipressin. So the fluid resuscitation with the albumin is recommended at 1 gram per kg of the body weight for 48 hours, and then reassess. And then the vasoconstrictors and the albumin are recommended in all patients with the stage 1 more than 1A. Albumin in patients with the spontaneous bacterial peritonitis. 1/3 of patients will develop AKI despite the resolution of the infection, which is associated with the increased mortality. In this study, they used the albumin in SBP to prevent AKI. There were 126 patients with the SBP, and they divided into two groups. In one, they gave the antibiotic along with the albumin. In another, they give only antibiotic. And then these were the results. And see, AKI in hospital and 90-day mortality was more common in the group without albumin. This is the long-term administration of the human albumin. In this study, they showed that the survival was better when they used the albumin in these patients for a long-term basis. This is the classical answer trial, in which they looked at the efficacy of the long-term human albumin in patients with decompensated cirrhosis. This was a multicentric randomized parallel open label trial in 33 Italian hospitals. Human albumin group, they initially loaded with the 40 gram twice weekly for 2 weeks, and then 40 gram weekly for up to 18 months. Then overall 18-month survival was significantly higher in the SMT plus the human albumin group than the SMT group. And the hyponatremia episodes also decreased. Ascites, the cumulative incidence of first paracentesis and refractory ascites was decreased. This is match study in which they involved 196 patients with a decompensated cirrhosis and ascites. These were patients awaiting the liver transplant. This was a double-blind, placebo-controlled trial. They gave midodrine and the albumin in one group in 99 patients, and the mido was given in the doses of 15 to 30 mg per day. The albumin was given 40 gram 2 weekly for 1 year. There was no significant difference in the development of complications, AKI, hyponatremia, infections, HE, or gastrointestinal bleeding, or mortality at 1 year. But there were many flaws in this study. Now, this is a pilot Preciosa study in which they tried the albumin for 12 weeks in decompensated patients, and this was given in the doses of 1.5 gram per kg weekly versus 1 gram per kg every 2 weeks. The high doses of albumin, There was a normalization of the albumin levels, left ventricular circulatory stability, reduced levels of the inflammatory cytokines, and there was no significant change in the portal pressures. And this is a entire study in which there were 777 patients hospitalized for decompensation, and they assessed the use of repeated infusions of the albumin to bring their levels to 3 grams per liter or more. The study was negative as albumin did not reduce AKI events, infections, or death. In phase study 2, here they assessed the albumin in patients with cirrhosis with non-SBP infections. There were 118 patients. Antibiotic plus the albumin was given, or antibiotics alone. A significantly higher proportion of patients in the study group had resolution of ACLF. A significantly lower proportion of patients in the study group developed nosocomial infections. There was no difference in the mortality. This is again the hyponatremia, the prevention of hyponatremia. This I have already told in the answer trial. This is NACL trial done by Bajaj et al., in which they also showed that the hyponatremia was lesser in those who received the albumin. The albumin can be used in some patients with the muscle cramps. Infections other than SBP have also been used, but in a meta-analysis of 407 patients included in 3 studies, the use of albumin was not associated with lower mortality at 30 days. The albumin can be used in the encephalopathy also. The problem with the domiciliary albumin are the allergic reactions and the transfusion reactions, volume overload, cost and availability. Administration requires a supervision due to the risk of adverse events, making domiciliary use difficult and potentially unsafe, requires further research on optimal dosing and long-term effects. So to conclude, the well-established indications for the use of albumin are large volume paracentesis, SBP and HRS. Promising uses but require additional studies in HE and hyponatremia. Evidence is lacking in decompensated patients and infections other than SBP. Allergic and transfusion reactions, volume overload, cost and administration requires supervision due to risk of adverse events. Requires further studies comparing the hospital-based and domiciliary albumin therapy. Thank you.
Question and answers will be after conclusion of
Okay.
session.
Viren,
Yes, sir.
can we ask questions? Viren?
From my side, yes, but ask the moderators and chairman.
Okay, never mind.
After the conclusion of session.
The problem with that is that you forget the question by the time it's over. So the last person in the firing line.
So now I would invite our next speaker, Dr. Radhika Chavan.
At the outset, I would like to thank Dr. Arora, Dr. Srihari, and Dr. Shivam for giving me this opportunity. In this talk, I am going to talk about EUS-guided vascular intervention, anecdotal reports, or an established modality. US has opened door for many EUS-guided vascular intervention. In 2000, first report of EUS-guided sclerotherapy was described for esophageal varices. In 2007, the feeder of a gastric varices was targeted under US with a glue injection, and in 2011, Kenneth Binmoller used glue plus coil for treating gastric varices. So, US allows visualization of intramural as well as extramural part. It allows the visualization of a feeder vessel. Under real-time embolization can be carried out. With US, you can inject a coil, which is impossible to inject with a conventional technique, and coil acts as a scaffold which reduces the volume of glue required, and thus embolization risk get reduced. So in this case, the feeder was identified. I have injected one coil. You can see the coil being deployed here, and following one coil injection, 1 ml glue was injected. So 4 centimeter varix got obliterated with one coil and 1 ml glue. So that is the beauty of endoscopic ultrasound. It reduces the volume of glue required, and under real time you can carry out the procedure. So from 2017 to 2007 to 2025, more than 500 articles have been published. Many of them are review article. Out of that, 7 meta-analysis are there. 3 has compared US with a conventional technique, 2 compared monotherapy versus combination therapy. One from Sridhar group, they have compared US with a radiological intervention, and one analyze the utility of US for primary and secondary prophylaxis. So this is our meta-analysis. In that we have compared US-guided therapy versus direct endoscopic glue injection. So in that, what we have found, the rebleeding and reintervention rate were significantly low in a US group compared to endoscopic glue injection, but the adverse event were comparable in the both group. And what other meta-analysis says that the technical and clinical success are very high with a combination group than a coil alone or a glue alone. The combination group is associated with a less rebleeding rate and less adverse event rate. So there are two routes of US-guided embolization. Either you can directly inject a coil into the varicose complex, or you can trace a feeder vessel which usually arises from splenic vein or left gastric vein, and you can target the feeder vessel. So you can treat actively bleeding varix, because whenever there is a lot of blood and you are not able to localize the source, you can use a endosona, and you can use EUS for a primary as well as secondary prophylaxis. So this is a guideline from ESG. They have also placed US guided glue injection and coil injection in a center where expertise are available. And this is a study, this is a meta-analysis from Saurabh Chandan group. They have analyzed role of US for a primary and secondary prophylaxis. The pooled rate of GV obliteration was very high when it was used for a primary prophylaxis, and the overall rate of rebleeding was around 5%. In case of secondary prophylaxis, this patient underwent multiple time glue injection. It was very difficult to target the area under endoscopic guidance. So we have used endosono. We could see a residual column of 1 centimeter, and it was accessed with a 19 gauge needle. It got hypershot, so there was spurting from counterpuncture, but my needle was within a column, so I injected 1 ml glue, and with that there was a complete obliteration of flow. And after that, patient had never had a recurrent bleeding. So for a secondary prophylaxis and those patients who underwent previously a glue injection, US can be a good modality to target the residual column. Compared to BRTO, this is from our group. We have compared, we have done a propensity matched analysis. In that, what we have found, the 4-week obliteration rate was similar in both US and BRTO group. Though the rebleeding from gastric varices more in a US group, it was comparable with a bleeding in a BRTO group. In BRTO group, bleeding was more from a esophageal varix, and the worsening of ascites and adverse event was more in a BRTO group. So in short term, the rates were comparable with a radiological intervention. But there are issues with the US guided embolization. The technique not yet standardized, how many coils, number of coils, and size of coils to be used, whether to target feeder vessel or varicose complex, and what is the role of other sclerosant like a thrombin instead of a glue, and safety and efficacy of this method in presence of a large shunt. But so far, this technique has a very good clinical and technical success, and it is associated with a less rebleeding rate, and it is established technique, not a anecdotal report. There are reports of a US guided embolization which has been used for ectopic varices. Only the problem, ectopic varices are rare in occurrence, occur in 5%. So we have case series only. The principle to treat ectopic varices is similar to that of a gastric varix. You can see the varix under US guidance, and you can treat with a coil and a combination therapy. Coming to the pseudoaneurysm, like ectopic varices, occurrences are rare. but can be targeted under endoscopic ultrasound guidance when they are endoscopically accessible. So this case was presented with a large subepithelial lesion. It was enhancing on a venous space because the neck was short. So we did an endosono. On endosono, we diagnosed to have this patient has a very large pseudoaneurysm. It was of size 5 by 6 centimeter, and there was a active oozing from a splenic artery. The splenic artery was traced to the pseudoaneurysm and confirmed that it was arising from splenic artery, and then it was targeted under US guidance. Multiple coils were injected. Following that, 1 ml glue was injected, and you can see there was a complete cessation of a Doppler flow and within a pseudoaneurysm. So this is the largest series from Pravir Rai group. So they have included 19 patients with a 20 pseudoaneurysm. They have given an algorithmic approach when to go for endosono guidance and when to go for a IR guidance. When less than 3 centimeter size pseudoaneurysm is there, very high technical and clinical success rate are there with the endosono. If more than 3 centimeter is there, they may require a interventional radiologist guided intervention. Coming to the US guided PPG, it is a new kid in the block. The first case report of US PPG was reported in an animal model in 2015. It, it has been a decade, but only few case reports and case series are there. We need a RCT to provide a standardized value of a PPG in comparison to the HVPG. PPG is a direct method. It does not require a fluoroscopy but requires a sedation. You can measure sinusoidal as well as pre-sinusoidal hypertension, and you can do this procedure along with a liver biopsy, US-guided embolization of a gastric varices. So it can be used as a one-stop for all endoscopic procedure. So this recent study, they have compared US PPG with a HVPG, not a RCT, but they found a very comparable value with a HVPG. So it can be used, but we need a more RCT and further studies to validate the values of a PPG. Some reports are there. These are like a US guided tips. It is called as IPSS, but shown in animal studies only. And there are reports of transhepatic portal vein stenting. These are anecdotal reports. There are reports of US guided portal vein thrombolysis. This is from Sharma group, and recently I think from GB Pant also they have reported that we can do a US guided portal vein thrombolysis under US guidance. And there are reports of splenic artery embolization for hypersplenism also. And these are case reports only. We need a case series and large sample size to bring this into the reality. But there are some reports, some of experience of mine that I want to share. The role of US for feeder vessel embolization. This was a case I have presented in previous conferences also. So this was a NET, and during dissection there was a lot of bleeding, and I was not able to visualize the source, and patient went into hemodynamic shock. So in this case I have used endosono, and with that I could detect a large spurting vessel which was targeted under US guidance, and following glue injection that bleeding source could be localized, and that bleeding got stopped. So from this case I have learned if there is a large feeder vessel we have to preemptively target that feeder vessel. So this was a case which presented with a GI bleeding, and there was a large subepithelial lesion around 4 centimeter. We did a CT, and in CT there was a large feeder it was coming from the splenic artery. During endosono we could see it, the lesion more predominant lesion was in a submucosa, only small infiltration was there in the muscularis propria. So what we did, we preemptively targeted this feeder vessel with a 19 gauge needle, and we injected adrenaline in this case. We did not go for a glue injection because we thought glue may hinder during further dissection. So we injected adrenaline at the base of the lesion, and you can see the instantaneous paleness of the lesion. And my ESD was a bloodless, and I could remove whole lesion, and there was no major bleeding episode, and the defect was closed. So to summarize, US-guided gastric varices embolization, we have sufficient evidence now. US-guided embolization of pseudoaneurysm and ectopic varices, safety has been established, but the disease is rare, so we have only case report and small case series. US-guided PPG, we need a further studies to standardize the value. US-guided stenting and thrombolysis, we have to wait for large studies. And US-guided preemptive embolization of a tumor feeding vessel, something which can be explored. Thank you.
I'd like to invite our next speaker, Dr. Sridhar Sundaram.
So very good morning to one and all, and at the outset I'd like to thank Dr. Arora for this opportunity. So I'm going to be speaking on cold snare polypectomy today. This is a brief overview of how I'm going to be dividing this talk. So clearly we know as the paradigm of endoscopic resection is expanding, we're dealing with, of course, pre-malignant lesions, but we're also going towards malignant lesions. But I think we started out with the pre-malignant lesions, and we're going back to the basics today. We're going back to conventional polypectomy and EMR. So I think all endoscopics, when they see a polyp, the only thing they think is kaat dalunga kaise bhi. But there have to be times when you have to decide when to defend and when to actually go ahead and cut the polyp. So there are certain essential considerations before you take a patient up for polypectomy, of course. And the first is, of course, the size of the lesion. As the size of the lesion becomes bigger, the risk of submucosal invasion and a higher grade in the polyp also becomes higher. Again, the morphology often dictates the choice of technique, and largely, of course, the histology and the risk of submucosal invasion, depending on your examination overall. And the last bit, I think we depend a lot on NBI now. I am not going into details, but we depend on the JNET classification, which is otherwise validated. And again, I think there is validation also done in the Indian setting by Dr. Naresh Bhatt's group. So yeah, this is what we're going to be doing. So we have to assess the polyp properly before we embark on any technique for resection. Now, how to approach? Now, this is an algorithm that I have devised, and I often follow this approach for dissection. So if you have a polypoidal lesion, you will typically look at JNET 2A or 2B lesions, which are good for endoscopic resection. And again, in those who are JNET 2A, 2B, you will look for patients who are having high risk features, like the very large size ones, the ones with an LST-NG non-granular type morphology, the Paris 02C, the slightly depressed ones, or the location in the rectum. And in those cases, maybe ESD is the best. But we are not talking about ESD today. We are going to be talking about cold snare polypectomy. So if none of these high risk features are there, we are largely looking at a discussion between cold snare and hot snare polypectomy. Now, before we go to cold snare polypectomy, you often have very small lesions, the diminutive polyps, and you often wonder whether we can remove these with a biopsy forceps alone. And if you ask, most guidelines will say no. But then again, is cold biopsy really all that bad when you're talking about diminutive polyps? So if you actually compare the rate of complete resection, if you have a jumbo forceps, the rate is going to be as good as a cold snare. And again, clearly retrieval is going to be much better with a jumbo forceps. So if you have a very small polyp, 3 to 5 millimeters, a forceps is not all that bad. You can do it with a forceps. So this systematic review again said that cold biopsy using jumbo forceps is as good as a cold snare. And failure is higher to retrieve, the failure of tissue retrieval is higher with a cold snare. But unfortunately, if you look at the recent ESG guideline, they say we should not be using a cold biopsy at all. But then again, I think we can individualize in practice based on what we see. And clearly, if you have a very small lesion, I think a cold biopsy is going to be as good. Then, of course, comes the slightly bigger ones, 6 to 9 millimeters. And again, there is a lot of data now. This is a last systematic review, again, showing that the rate of incomplete resection is not different between cold snare and hot snare. And also, the adverse event rate is much lesser with a cold snare. Now, what are the adverse events that we are looking at? The bleeding rate is somewhere to the tune of 2%. And sometimes patients may have pain. Now, all of these studies tend to over-report pain. They may be to the tune of 10, 12, 15% in a lot of studies. I don't know how significant that is. I don't know how many of you actually see that in practice, that a patient who's undergone a polypectomy for a 10 millimeter lesion is actually having a lot of pain. But then again, clearly cold snare is safe, effective. So I think for 6 to 9 millimeter lesions, I think even the ESG guidelines would say it's possibly the best technique to use. Now, what about polyps more than 10 millimeters? Now, would you really do a cold snare for these? Now, the problem is, the recurrence rate. Now, the overall recurrence rate, if you look at all polyps, is around 4%. But if you look at polyps that are bigger, more than 20 millimeters, it's going to be around 15%. And again, adenomas, the recurrence rate is going to be very high, to the tune of somewhere between 10 to 20%. So clearly, you would be more cautious if you have a lesion that is more than 10 millimeters in size. But if you look at comparative studies, this is again a large systematic review, again published in JGH only 2 years back, and again they found that the rate of incomplete resection was not very different, and the adverse event rate was much lower with cold snare. So then again, you can select patients who are between 10 to 20 millimeters of size, and if they are appropriately selected, maybe cold snare can be done in these patients. What about sessile serrated polyps? Again, this is a systematic review which showed that in sessile serrated polyps, on the other hand, hot snare doesn't fare as well as cold snare. So, cold snare fares better than hot snare, even in terms of the resection rates, because they are much flatter, more difficult to identify. So, typically, cold snare does even better than hot snare in these cases. And for polyps, more between 10 to 20 millimeters, which are sessile serrated, cold snare polypectomy is the way to go. So what does the guideline says? Again, for more than 10 millimeters, hot snare may be preferred because there's a reasonable amount of evidence. But then, for sessile serrated lesions, you can do a cold snare polypectomy. And, if you have dysplasia, and if you feel that, the sessile serrated lesion is tending towards having a higher grade of a polyp, then maybe a hot snare should be better. And again, in carefully selected patients for 10 to 19 millimeters, you can consider doing a cold snare. What about more than 20 millimeters? I think there are a lot of trials that have come in the recent past. Over the last 2 years, there have been 3 trials, all of them talking about cold EMR. So anything that is more than 20 millimeters, they're talking about cold EMR. So this was again, this is a German, this is a multi-center European group published in Gastroenterology, the Chronicle trial. And they again showed that the rate of major adverse events were much higher, around 7% in hot snare versus 1% with cold snare, but residual lesion was much higher, around 23% with the cold snare versus 14% with the hot snare. So clearly, residue recurrent lesions are much higher with a cold snare. What about, again, this is the Spanish group. They again published very recently, maybe 1 month back, in endoscopy, 229 patients. Again, they showed that the rate of recurrence at 6 months, when they actually went back in for an endoscopy, was much higher with a cold snare EMR than your standard EMR with a hot snare. So again, if you have a lesion that is more than 30 millimeters, it's even higher. And the thing is, in this particular study, this was randomized, and the adverse event rate was very similar, despite having the larger size of polyp. And the one thing that was interesting was their use of clips. So clearly, even if they had a bleeding, they were able to use clips to close. So that is one thing that was significant, at least in this study. And lastly, of course, this study published in Gut. Again, this is Sunil Gupta's group, Australia. So again, the same thing. The primary outcome was recurrence and clinically significant post-EMR bleeding. The recurrence rate was much higher with cold snare, and at the same time, the bleeding was much higher with the hot snare. So clearly, for lesions that are more than 20 millimeters, you may not actually do cold snare. And I think this systematic review just published recently in June summed all that up to say, yes, for larger lesions, cold snare is not as good. The recurrence rate is much higher. The adverse event rate may be slightly higher in the hot snare, but clearly the recurrence rate matters for these lesions because these are likely to be higher grade lesions. So question is, when is cold snare preferred? So clearly cold snare should be preferred for all polyps less than 10 millimeters, sessile serrated lesions regardless of size. And again, for adenomatous polyps, there are well selected between 10 to 19 millimeters, you can consider doing a cold snare resection. Again, you know, you may use cold EMR for non-pedunculated conventional adenomas more than 20 millimeters if you are sure that the patient will come back for follow-up. You're reasonably sure that you will be able to get the lesion out well, and again you're sure that there are really no other options to offer. So coming to the technique, it's rather simple. You want to get the polyp to 6 o'clock, you have a snare, you try to fix it on the opposite wall, eventually go across, get a thin rim of mucosa surrounding it and cut it on block. And you can actually see the base rather well. So yeah, so this is the entire base that you will see. Troubleshooting, again, clearly you want to, the optimal position is 6 o'clock. The 3S techniques, you assess the polyp first. So the site assessment, the snare resection, and the site inspection again is what you do. You need to know your accessories well. And the appropriate size of a snare, and there are, I think, the X-Acto snare available from US endoscopies, which is a standard cold snare. But then again, if you're using the right snare, you don't want to use a very, very big snare for cold snare polypectomy because you're trying to make sure that you're hinging it somewhere and then pulling back. So, and make sure that it is on block. So to summarize, appropriate examination is a must prior to endoscopic resection. Cold biopsy in diminutive polyps can be done using jumbo forceps. Clearly, that is something that we did not know. Evidence is there. Cold snare is the way to go for polyps between 6 to 10 millimeters. For 10 to 20, careful selection. More than 20, best to avoid. And there is a standard technique which we must follow. And as a rule, I mean, I often say this to my students, but as a rule, just like in the case of panipuris or golgappas over here, you want to make sure that you get the whole thing out and not in pieces. You will not enjoy it if it's in pieces. So clearly, that's I guess the take home here. So for a polyp, always make sure that it's as a whole and not in pieces. Thank you.
For our next talk on cystic lesions of pancreas, we would like to invite Dr. Vikas Singla on stage.
Good morning to all of you. At the outset, I'm thankful to Dr. Anil, Dr. Ashish and Praveen for the kind invitation. So I will be discussing regarding decision making in a patient with pancreatic cystic lesion, no disclosures. So we know pancreatic cystic lesions are increasingly diagnosed. Our threshold for doing a CT scan is reduced. We are seeing more and more pancreatic cystic lesion, and definitely they have a malignant potential. Here we can see a cystic lesion, thin wall, then it becomes thick wall. It's malignant potential. Then it has a mass, so it's frankly malignant. And there are various types of pancreatic cystic lesions. On the left side, these are benign lesions. They can be pseudocyst and the cirrhosis adenoma. They don't require any treatment except for the symptomatic pseudocyst. On the right side are the frank malignant pancreatic adenocarcinoma, NETs, and they require surgery. But the lesion in between IPMN and MCN, they have a malignant potential, and the treatment has to be individualized in this scenario. So left side lesion you follow, you can leave, and the right side they need surgery, and in the central one we have to do a decision making. And these are the Fukuoka guidelines, Kyoto guidelines for the branch duct IPMN, and they have suggested that patient who have high risk stigmata, duct more than 10 mm or the nodule, they require surgery, and patient with the worrisome feature, they should be further evaluated with the EUS. And patient who had a main duct involvement and the nodule for more than 5 mm, they require surgery. So whenever patient with the pancreatic cystic lesion come to us, we should have a good history. Based on the history, we can sometimes differentiate whether it's a pseudocyst or a cystic neoplasm. Any patient having chronic pancreatitis with the cystic lesion, it's likely to be pseudocyst. And patient having asymptomatic lesion, likely to be cystic neoplasm. And MRI should be the next investigation. MR-angio with the MRCP should be the next investigation, and few patients may require EUS, and then few patients may require the sampling. So on MRI, we can see this is the branch, the main duct IP and MPD is dilated, doesn't require any further investigation. Patient can be subjected to surgery. This is a MCN. We see a large cyst with the small septa inside. And the mucinous, all the patient can be referred for surgery. Mostly they are the young female, and the lesion is confined to pancreatic body and tail. So various societies recommend surgery for all the patients with the mucinous cystic neoplasm, and few societies they recommend surgery if the only size is more than 3 centimeter. Otherwise, all the mucinous can be sent for surgery. Cirrhosis adenoma occurs more in the elderly patient. Mostly they are asymptomatic, and they can be left as such. They don't require any treatment. No follow-up is required. Then the span occur in the young female, second decade, third decade, and they have a malignant potential. They should be offered surgery. So we have to individualize treatment in the mucinous cystadenoma and the IPMN. And the cystic NET, they will require again surgery. And if on MRI, the MRI should be the first modality. If on MRI we are not clear about the diagnosis, then only we should go ahead with the endoscopic ultrasound. So this is a bunch of grape appearance, suggestive of BDIPMN. This is a cyst with the daughter cyst inside. This is MCN. This is serous cystadenoma with the honeycombing appearance. This is the unilocular cyst. So here there can be multiple differential diagnosis. This can be MCN, this can be unilocular SCN, and this is the span, and these are the BDIPMN. So after the EUS and MRI, we will have this type of appearance. So first is the unilocular lesion, and third is the oligolocular lesion. Second is the honeycombing, and last is the mass appearance. So there is no confusion regarding the second and the fourth. Second will require follow-up, and the fourth will require surgery. But the confusion occurs in the first and the third lesion. Here various differential diagnoses are possible. The first and third, they can be a pseudocyst, it can be a mucinous cyst adenoma, it can be a unilocular or oligolocular serous cyst adenoma. So in first and third, there are multiple differential diagnoses, and we should do further evaluation, and one should go ahead with the cyst fluid sampling. If the cyst fluid amylase is more than 25,000, it suggests it's a pseudocyst. If Ca is more than 192, it's suggestive of it's a mucinous lesion. And glucose is a very good test. The mucinous cystic neoplasm, they are metabolically active lesions. They will consume the glucose inside the cyst, and the glucose level will be low. So on the bedside, we can diagnose it's a mucinous cystic neoplasm. Then at few centers, we can do the molecular markers. We can look for the KRAS and the genus mutation. So the Ca and the glucose, they are good tests to diagnose a mucinous cystic neoplasm. Low glucose suggests it's a mucinous cystic neoplasm, and KRAS and genus will be positive more in patient with the mucinous cystic neoplasm, and especially the patient who are having dysplasia or high malignant potential. And few patients may require the confocal laser endomicroscopy, which can diagnose whether it's a SCN or it's a mucinous cystic neoplasm. So after the sampling, so once you have done the Ca and the glucose level and the amylase level, the cyst can be characterized as either it can be a serous cystic neoplasm, it can be a pancreatic pseudocyst, it can be a mucinous cystic neoplasm, or it can be a indeterminate. That after the sampling also we are not able to make a diagnosis. So serous can be follow up, pseudocyst can be drained if required, MCN again that they can be operated, but indeterminate again treatment has to be individualized. Now coming to the pancreatic cyst ablation, so none of the society they recommend ablation for the pancreatic cystic neoplasm as a routine treatment. It should be offered only in the setting of a clinical research and the trial. So how we do the pancreatic cyst ablation? What are the cysts which are good candidates for the ablation? What are the agents, and what's the technique, and what's the outcome? So the cysts which are unilocular or oligolocular and which are mucinous cystic neoplasm, or some trial have taken indeterminate also. So cysts which are either mucinous or the indeterminate, and the number of locule 2 to 6 and diameter more than 2 centimeter, they can be offered the pancreatic cystic ablation. And if the size is less than 2 centimeter, the cyst ablation should be avoided. There are more side effects. Now coming to the agents, so alcohol has been used along with the paclitaxel, or paclitaxel alone or with the gemcitabine has been used in the previous trial. So if we see the 19 or 22G needle can be used for the cyst ablation. 19G may be difficult to pass through the scope, so better to use 19G nitinol needle that is more flexible and can be passed inside the scope. So we go to the cyst area with the 19G, we aspirate the fluid and we replace it with the equal volume of with the therapeutic agents. And so with the alcohol we have to do the lavage. So we leave the alcohol inside for 3 to 5 minutes, then we re-aspirate the alcohol, and the paclitaxel has to be infused. We don't have to re-aspirate. We inject paclitaxel in the cyst and leave it for a long duration. So these are the outcome with the alcohol and with the paclitaxel, and we can see the complete remission rate is between 35 to 70%, but right side column is the worrisome. So we can see these are the cystic lesion with the some malignant potential. Mostly the patients are stable, but with the alcohol there are concern of serious side events. Patient can have pancreatitis, splenic vein thrombosis, and sometimes there is reports of gastric wall perforation also. They are very serious adverse events. So this is a large study by Japanese group, Korean group, 164 patients, and they have taken both the MCN and the indeterminate lesion in their study, and they injected alcohol lavage followed by the paclitaxel, and we can see they have taken mucinous, serous, and the indeterminate. And if we see the complete remission rate, that is 95% reduction in the volume. It's not the diameter. 95% reduction in the volume occurred in 70% of patients, and most of the patients they were in remission at the 6th year. There were hardly any recurrence. So alcohol and paclitaxel combination was very effective in this study, but there were serious adverse event. The patient had acute pancreatitis, cirrhosis, thrombosis. So they are not acceptable in a patient who have a stable lesion with the questionable malignant potential. So then came the CHARM trial. So they involved only patient with the mucinous cystic neoplasm. So there were 2 arms. It's a randomized control trial. One arm received alcohol plus paclitaxel plus gemcitabine, and in another arm it was alcohol was replaced with the saline injection, and they took only mucinous. And in both the arms we can see the complete remission rate occurred in 65 and 61% of patients. And when we see the adverse events, in the alcohol free arm there was no serious adverse event, but in the alcohol arm 28% of patients they have serious adverse event. So it means alcohol is a culprit. It should be avoided for the pancreatic cystic ablation, and most of the patients who had reduction in the cyst size, they were able to maintain the remission in a long term. So even after the cyst ablation, patient has to be followed up, because the cystic neoplasm, it's a field defect. In other sites again there can be recurrence of the cystic neoplasm, so patient should be followed up. As of today we don't have any head-to-head trial with the surgery, so patient has to be followed up for a longer duration. So this is as of today. We manage this patient. High risk patient, they go for surgery. Low risk, they undergo surveillance. But the future can be patient with the high risk go for surgery. Low risk patient can undergo ablation. Patient who had a complete ablation, we can declare it's a cure. And patient who have persistent, they can be undergo further surveillance. So to summarize, pancreatic cystic neoplasm, they require a tailored approach. Patient who have a serous cystic neoplasm, they can be followed up. Patient with the NET, ductal adenocarcinoma, SPEN, they require surgery. MCN surgery can be offered to all the patient, and few society recommend surgery for size more than 3 cm. EUS-guided cyst ablation is an effective technique. Mucinous cyst and the BDIPMN size 2 to 5 cm, oligolocular lesion, they can be offered endoscopic ablation. Alcohol has been commonly used but associated with the serious complication. I think paclitaxel and gemcitabine is the best combination, which is equally efficacious and without the side effect. And we can expect a remission rate of 70% in these patients. And once they have a remission, they maintain remission for a long duration up to 6 years. Thank you very much for a patient hearing. So these are the beautiful flower from the Persian yew tree, which is a source of paclitaxel, which is used for the patient with the pancreatic cystic neoplasm. Thank you very much.
Yeah, being a surgeon, yes, I have. I mean, yes, indications for surgery is already, I mean, you have already mentioned that. My question to you is there a role for radiologically discovered cysts which aren't of that size and asymptomatic, whether you go in for ablation or there is a period that we can wait and watch surveillance.
So whenever we have a cyst, mostly they are diagnosed on the CT scan. So next we should have a differential diagnosis. So if it's serous, they can be followed up. And if your own CT scan, it's very clear, it's a solid mass is there, they should be offered surgery. So if you have a suspicion of whether it can be pseudocyst, serous cystadenoma or mucinous, you go with the endoscopic ultrasound with or without aspiration. So if it's a mucinous and the BDIPMN, then there is a role of ablation. Serous, I don't think they require any treatment.
At today's age with MR and CT scans, I mean, the quality is so good.
So-
Do you still need the aspiration for those
So
markers?
mostly we are able to make a diagnosis, but the confusion, so if it's more than 3 centimeter, mostly we are able to diagnose whether it's benign or malignant. The confusion occur when the size is less than 3 centimeter and there is no solid content. Then you go with the EUS. Sometime based on the EUS finding alone, you can make a diagnosis. So if the EUS morphology is not diagnostic, then you go with for the aspiration. So very few patients with the may require aspiration. Not all the patient will require aspiration. So you see morphology on MRI first, then EUS morphology, then aspiration.
Because I've been seeing for last 20 odd years. I mean, this aspiration and all has been sort of
Yes,
people
yes.
are doing very less
Yes.
for aspiration because
So very few patients I think require aspiration, and I think sometimes we miss the role of history also. So we should always take history of pancreatitis. So imagine one first imaging there was no cyst, and on the second imaging we had a cyst, and in between patient had a pain. It's nothing but pseudocyst. But if on the first imaging there is a cystic lesion, so it can be either a cystic lesion which led to pancreatitis, or it can be a pseudocyst. So history and examination, I think nothing can replace a good history and examination.
yeah, nothing can replace that. Thank you.
Thank you, sir.
This is what I was saying. The last person is targeted always. So Sridhar, in the cold state, there's more recurrence as compared to hot snare. That's because of the thermal effect. And can we do a cold snare and do a cautery of the base to reduce the recurrence?
That technically becomes the same thing, right? I mean, you are
No, no.
cauterizing at the end of the day.
No. Hot snare. If you use hot snare, there can be a delayed perforation. That's the problem.
So if you look at data, the risk of delayed perforation is not so much. The risk of delayed, if you look at all the studies.
My first question: is it the thermal effect that prevents recurrence?
Yes, absolutely, because that leads to ablation. But then again, the complications that are reported are largely bleeding and not delayed perforation. Even in all the studies, it's bleeding that is reported. Perforation is rare, especially delayed perforation is rare.
So it can happen because there has to be a thermal injury that can
Clearly.
perforate.
Of course, it can happen.
Yes. So if you just do a ablation of the area, say APC, or just because touching the snare with a hot
You can do that, but at the end of the day,
does it prevent recurrence? Are there studies?
It should prevent recurrence because
Sure.
there is a lot of data.
Logic over there.
Yeah, there is a lot of data on margin ablation for EMR. So
Margin as well as the base.
you can do that, but at the end of the day, it's going to be pretty much like a hot snare.
You're just touching it. You're not grabbing it in toto.
Yeah, I mean the data is only for the margin and not for the base, but nevertheless.
I have a question for Dr. Chavan. You mentioned in your presentation about primary and secondary prophylaxis for EUS-guided call plus glue. So when you choose for primary prophylaxis for gastric varices, does the size matter? Does anything that matters to do a primary prophylaxis with an intervention procedure like this?
Thank you for question, and it's really nice question. So there is no cutoff value, but some studies they have shown if size is more than 1.7 centimeter and child sees cirrhosis, in that case we have to go for a primary prophylaxis. We can.
Thank you.
In continuation, Radhika, if you are there, here.
Okay.
How far are we for EUS-guided tips? So you can puncture portal vein, you can see beautifully hepatic vein. Why not connect the two?
Sir,
Or
actually-
else IVC with the left portal vein?
They are not in an axis, sir. We can puncture a portal vein.
Yeah.
We can separately puncture a hepatic vein also, but they are not in the same axis. So that is the problem. Still, it's difficult to interpolate these animals findings into the human things.
But they are also not in the access for IR people also.
Yeah, but sir, yeah.
So I feel there are two issues here at hand. The first issue is that you're going through a luminal structure while the IR fellows are going through the vascular structure. So they are puncturing one surface. So it is from one vein to another. So for them, it's a single puncture. For us, it's going to be two structures that we are going to be trying to target and speculating that we are actually targeting. Clearly, so the second issue remains, what do you do about the tract and how do you make sure that, so for most interventions that we do in gastroenterology, we create tracts such that we are able to, salvage if there is an issue. Now, in this case, I'm sure, just like in the case with IR, I'm sure they also do not have much of a salvage. We also will not have a salvage. So clearly, I do not see EUS-guided TEPs happening anytime in the near future, at least.
Not even dips. IVC is pretty close to the left portal vein.
So like I said, sir, people are going to experiment with things. So if you look at publications in gastroenterology journals over the years, you will always find, one article in one of the big journals which says they've punctured some structure with a 19 gauge FNA needle and some recess that they've accessed with a 19 gauge FNA needle. So if you're asking me, EUS is going to expand. Clearly, someone is going to try something new. But is this going to be common practice? I really do not think so.
In this, actually, two vascular structure has to be connected, sir. And that is, I think, difficult to do with the endosonate because it's a 2D study. We don't have a 3D. And they are going through the lumen, what Sridhar said. And in animal study, what they have done, they have punctured a hepatic vein, and with guide wire, they tried to go into the portal vein, and over the guide wire, they have deployed the axios. But animal, maybe they are in axis. Human, definitely they are not in the same axis.
Thank you. I think.
This is Dr. Radhika. This is regarding the US interventions. In such a the gastric varix which you showed, if you inject the one coil and with a 1 ml of glue, it will not be successful.
So I have injected that in a feeder vessel.
So that's very important.
Yeah.
If you are injecting in the feeder vessel, then it is fine.
Yeah.
If you inject one coil and 1 ml of glue in a large varix, it will not be successful, and many times it may happen that the glue and the coil may come out through the stomach, and then may lead to the again the rebleed, and in that case you have to target the feeder vessel.
Yeah. So for varicose complex, if it is around 2 centimeter, we have to take a coil which is more than a varix size, 30% of the varix size. So when you are embolizing a varicose complex, you need a more coils. Feeder are small, around 1 centimeter. So one coil and one glue is enough when you are able to identify the feeder and target the feeder. So one coil and one glue enough for feeder. Definitely for varicose complex, we require more 2 or 3, sometimes 4 coils also.
Regarding the partial splenic embolization, in that case, you have gone through the literature. What are the effects on the portal hypertension if suppose you have done the splenic embolization, the partial one? What will result in the portal hypertension?
Portal hypertension gets aggravated, sir, and patients have a splenic abscess and splenic hematoma also following up splenic artery embolization. So there are only 2-3 case reports of a EUS-guided partial splenic artery embolization that was used for hypersplenism.
Sorry, we're getting quite late now. We come to end of this session. Thank you for speakers and the participants. Very interesting session. Thank you.
Thank you, everyone. For our next session, we would like to invite our moderators, Dr. Anil Rastogi, Dr. BPN Kaushik, Dr. Jaiprakash Bhatt, Dr. Zubin Sharma, and Dr. Suresh Madan Rasaili. Our chairpersons, Dr. Ajay Singh, Dr. Vikrant Singh, Dr. Arun Khanduri, Dr. Sandeep Rajkuar, Dr. Amritangshu Borkokoti. Our speaker for the first session, Dr. Harshad Devarbhavi, who will speak on challenges in primary and secondary prophylaxis of SBP amidst increasing antimicrobial resistance in India.
Yeah, I would like to first thank Dr. Anil Arora, Dr. Ashish, as well as Dr. Praveen Sharma for the invitation to be here. The common bacterial infections in cirrhosis are the following, but spontaneous bacterial peritonitis constitutes or ranks first amongst all infections. And particularly in our country, soft tissue infection, including cellulitis, seems to be unusually very common. So my task today is to talk on spontaneous bacterial peritonitis. In outpatients, it's about 3 to 5%, but increases to about 7 to 30% in hospitalized patients. Now, why is it important? Because of the poor prognosis. Despite all the advances in medicine and antibiotics, the mortality still continues to be about 20 to 30%. And the 1-year recurrence of SBP is about 70%. Now, for antibiotic prophylaxis and cirrhosis, now there are several indications in antibiotics. And for gastrointestinal bleeding, this is the standard of care, and you have the antibiotics that are listed. For secondary bacterial peritonitis, again, looks like it's a standard of care where you prevent bacterial infection and you use norflox or ciprofloxacin. What is contentious is the primary spontaneous bacterial peritonitis, and there are few indications that are available, and that one includes 1.5 grams per deciliter. So again, antibiotics are the same, norflox and ciprofloxacin. Now let's look at the guidelines of different societies for primary prophylaxis. So you have EASL as well as ASLD, and they have these guidelines where the ascitic fluid protein should be less than 1.5 and severe liver disease. And I've listed the criteria for severe liver disease, which include CTP more than 9, bilirubin more than 3, as well as AKI more than 1 point, creatinine more than 1.2. Now, if you come at the APASL, the same criteria except the word individualized is used. And for British Society of Gastroenterology, they are not very clear, but looks like they probably have the same criteria, that's ascitic fluid protein less than 1.5 gram per deciliter. Now, how long should we use it? Now, you'll notice that all of them say either you use it till the disappearance of ascites, or till death, or till liver transplantation, or ascites is at least resolved. And it's very common in patients who have alcoholic liver disease where ascites resolves pretty quickly. Now, the antibiotics that are listed to be given are either norfloxacin or ciprofloxacin, trimethamine, sulfamethoxazole. And these are the antibiotics that have been given throughout the world. And what is less surprising to me is that norflox is really not available in many countries. And the societies in countries where are not available, they still continue to say use norflox. For example, it's not available in Britain, it's not available in the USA after 2015. Now, I have listed several studies, and I'll just explain to you before I go ahead. So, you have the studies, names of the authors in the first column. Then you have this intervention, and most of them are either antibiotics with placebos. Most of them are placebos or with other antibiotics. And the green colored ones are the blocks, are the ones where these are included criteria. As I say, included the albumin less than 1.5, AKI and all those. And yellow means either the criteria are not there or it's not listed in the studies. And then the last one is about a spontaneous bacterial peritonitis. And you'll notice of the 5 slides, 5 studies, that everywhere where spontaneous bacterial peritonitis, there's statistically significant decrease in occurrence of spontaneous bacterial peritonitis. Now, what about mixed primary and secondary bacterial peritonitis? Again, 4 studies. Last study is the last one, 291 patients. You'll find that again, it's at least 3 out of the 4 suggest that there's statistically significant decrease in the occurrence of spontaneous bacterial peritonitis. So overall, it suggests that probably we should be giving prophylaxis for primary spontaneous bacterial peritonitis. But here is the crux. Now, you'll find that when you look at the resistance to antibiotics, you find that quinolone resistance is significantly more common when these patients have been treated with antibiotic prophylaxis. And you'll see almost all studies showing that the quinolone resistance increases. Not only that, you'll also find that mortality, except for one study, the top study by Fernandez 2007, where mortality decreased, but all the rest, the mortality just didn't really make a difference. And again, in the mixed primary and secondary bacterial peritonitis, you'll again notice all the 4 trials, there was no mortality benefit when you had given these patients primary prophylaxis. Now, what about secondary bacterial peritonitis? And here, this was this trial that has been there, published first in 1990, and subsequently no trial for 35 years have been published regarding secondary bacterial peritonitis. Spanish study, 80 patient, Norflox versus placebo, duration 1 year, and then you notice that the spontaneous bacterial peritonitis developed in 12% versus 35%, significant. But again, it didn't make any difference to mortality. There was no mention about antibiotic resistance as well, and again, as well as the complications. So again, this study has now held, it's been so important that nobody has done any more studies after this important study. So it has held sway over people's imagination for the last 35 years. Now I have listed all about 6 studies, and you'll find that these studies have, and these are references below. They used norfloxacillin versus another drug, or trimethoprim sulfamethoxam versus another drug, and also about rifaximin. The duration is 6 months to 1 year. Spontaneous bacterial peritonitis doesn't really make any difference in 4 out of the 5 studies. And what was more, 5 out of the 6 studies, there was increased antibiotic resistance. So these are really very significant, especially with regard to our country. Now, this is the map of the whole world, and what strikes out is the dark colored India, where you find that the antibiotic resistance, the multi-drug resistant antibiotic resistance, is more than 50% when you compare to several other countries in the world. And looking at the same thing, look at India, 73% of multi-drug resistance, USA 16%, European Union is only 16%. And what about extremely drug-resistant bacteria? You find 33% India. Worldwide is 10%, Canada and Switzerland only 0%. So we really have a problem with antibiotic resistance and extremely drug-resistant bacterial resistance. Now let's look at the in vitro susceptibility to different antibiotics, and the 3 common antibiotics. You find the 3rd generation cephalosporin that we all use and where everybody else in the use. The susceptibility in India is only about 48%. You can just toss a coin and decide whether they're going to work or not. What about piperacillin tazobactam? 48%. And carbapenem or meropenem is only 71%. So again, only a few, large number of patients have antibiotic resistance. And what about USA? You notice that they have, in fact, with regard to carbapenem, almost all patients, all antibiotics are sensitive, all bacteria are sensitive to carbapenems. So again, we have a peculiar situation where more than 50 to 70% of patients have antibiotic resistance. Now, I looked at the annual report of the Indian government, or the ICMR, and this is the antibiotic resistance research, and I picked up only one organism, that's E. coli. And look at this susceptibility at 2021. You find quinolones that has been advised to be given in patients who have for prevention as well as treatment, or SBP, 17 to 19%. So basically, they are in the teens. So it's in the teens with regard to quinolones and cefotaxime, just 16%. Piperacillin tazobactam, 47%. Meropenem 60s, amikacin about 80%, and only colistin is 99% sensitive. Now, 2 years later, you find that again it has dropped. The susceptibility is from 17, now it's about 13%. About cefotaxime again dropped from 16 to 14%, and again all drop in all the other antibiotics. Only colistin tends to stay sensitive to at 99.3%. Now, with regard to trimethoprim sulfamethoxazole, again these are not acidic fluid, but these are different body fluids. You'll find that approximately about 50% of them are sensitive to trimethoprim sulfamethoxazole. And why do I say it? I'll have a slide coming up later. Now, before I end, I would like to talk about this important study, and this is by Bajaj et al., both studies published this year. 4,673 veteran patients, so they are little older patients, and you are equally divided about 54 and 46, started on secondary bacterial peritonitis. You look at the recurrence. The SBP recurrence was 24% in those who had secondary prophylaxis, and only 14% who did not receive prophylaxis. That was significant. And what about infections? Non-SBP infection, again, much more common in those who received bacterial peritonitis prophylaxis. Again, this is again their own study, another group of patients, little younger, 56 years old, the mean age. You find that 50-50, about 3,000, and you'll find SBP recurrence again 23 versus 16%. Much more common in patients who received antibiotics. And then what about non-SBP infections? Again, significantly more in those who received antibiotics. Again, antibiotics are really harmful. And you'll notice again this, that the hazard ratio or 82% risk on those patients who received antibiotics than those who did not receive antibiotics. So antibiotics are giving rise to some problem. And again, they came up with this editorial, rethinking antibiotic prophylaxis of spontaneous bacterial peritonitis in patients with cirrhosis. First, do no harm. So I think really we need to look at how we can use these antibiotics. And finally, this important trial that has yet to be published, but I know from Guru Prasad Aital that this study has now ended. They have also analyzed this study about giving trimethoprim, sulfamethoxam, very easy to give, very cheap in this country. And at least because we don't use it much, a significant number of patients probably will be sensitive to this antibiotic. So in conclusion, primary prophylaxis clearly doesn't look like should be using it. I've spoken to experts who have written those guidelines, they don't give it. Secondary prophylaxis, again, there's a problem, especially with regard to our country. You can give it if you want to, but keep it brief and make it individualized. Infections, MDR, really it's a shame that we have such a large number of increasing MDR incidence and prevalence in our country. And if at all you want to use antibiotics, use it judiciously. Talk to your microbiologist in your institution about the local antibiogram and only use it for a short period of time. Thank you.
For our next talk, we would like to invite Dr. B. Jayanti for her talk on science and art of burping, gas, bloating, and hiccoughs.
So good morning to one and all. Thank you, Dr. Arora and his team, for this kind invite. So in the next 8 to 10 minutes, I shall be taking up definitions of 4 important clinical situations that we come across in our day-to-day practice, which are clinically interlinked entities, and they are namely the abdominal bloat, the distension, belch phenomenon, and hiccups. And what I'll be discussing will be the pathophysiological mechanisms of these entities. I will not be discussing the clinical presentation, diagnosis, and management, and that is beyond the scope of today's presentation. Now, the terms aerophagia, belch, abdominal distension, bloat are used interchangeably. When these symptoms are severe and frequent, affecting the day-to-day performance, these together constitute what is called as the disorder of the gut-brain interaction. Now, moving on to the definitions of abdominal bloat and distension. Abdominal bloat is a subjective feeling of fullness in any quadrant of the abdomen and is due to excessive gas accumulation in the stomach due to either food intolerance, swallowed air, or an underlying digestive disorder. Contrary to this, abdominal distension is a visible increase in the girth of the abdomen. By Rome-4 criteria, the symptoms of bloat and distension together constitute the DGBI, with symptoms occurring at least once in a day in a week for at least 3 months and with onset of symptoms predating at least 6 months. And most importantly, they are in the absence of abdominal pain or alteration in the bowel habit. Isolated, both distension or bloat, the prevalence is just about 3.5%. But when it is in combination with the functional dyspepsia, the IBS, or constipation, this almost exceeds 50%. Now, coming to the pathophysiological mechanism for bloat and distension, primarily in health, as is seen in this cartoon here, when there's an increase in intestinal gas, the anterior abdominal muscles actually contract and the diaphragm relaxes, thereby preventing the abdominal distension. This is what is normal. In functional bloat or distension, there is a paradoxical contraction of the diaphragm and relaxation of the anterior abdominal wall, as is seen here in this slide. And this is referred to as the abdominophrenic dyssynergia. which is essentially a paradoxical viscerosomatic reflex. Breathing behavior or breathing exercises are one of the modalities for management of these patients. Now, coming to the pathophysiological mechanism for bloat and distension, primarily in health, when one sees the, as is seen in this, there's an increase in anterior. So when one sees in this particular table the isolated abdominal distension and bloat due to either visceral hypersensitivity or abdominophrenic dyssynergia, it is essentially an exclusion of diagnosis when common causes like constipation, food intolerance, celiac disease, or non-celiac gluten sensitivity, SIBO, and other organic disorders are excluded. These patients, unlike the ones with known causes, would respond to non-pharmacological therapies like diaphragmatic breathing, exercises, use of neuromodulators, and brain-gut behavioral therapies. Now, moving on to the belchers and neurophagics. The belch phenomenon normally is an audible escape of air from the esophagus into from the stomach into the pharynx. During the excessive belch, this is actually a disorder when it is bothersome and it disrupts the patient's day-to-day activities and occurs more than 3 days per week. In aerophagics, this is actually excessive swallowing of air. There is an increase in intragastric gas that moves aboral to the intestine. So it is not related in the stomach, but moves to the intestine. And these are the symptoms of bloating, distension, and increased flatulence. And in these patients, belch is uncommon. Broadly, belchers are classified as gastric belchers and supragastric belchers. In gastric belching and aerophagia, the air-induced distension of the proximal stomach actually causes a TLESR, that is transient lower esophageal sphincter relaxation, that is vaguely mediated. This allows the gas to be released in a retrograde manner to the pharynx, resulting in secondary peristalsis in the esophagus and relaxation of the EUS due to the pressure gradient. And this results in what is called as the burp. These physiological changes are confirmed today by impedance pH monitoring. The belch is usually followed by a liquid reflux due to retrograde decrease in the impedance. So this is what is called as a gastric belcher. Contrary to this, the supragastric belcher is actually a behavioral disorder. In this type of belch, there are two distinct maneuvers. One is the air suction method, where the EUS relaxation occurs before the influx of air into the esophagus. This allows the air to flow into the esophagus more quickly and is independent of the esophageal peristalsis. In the air injection method, there is influx of air into the upper esophagus by means of an elevated pharyngeal pressure by contraction of the base of the tongue, rather than the peristaltic contraction of the pharynx. So this results in a deliberate belch. During this phenomenon, the patient has a fullness in the chest and there's a repeated movement with resulting contractions, and that is responsible for the supragastric belching. What are the risk factors that induces the belch? These factors include the psychological factors. We have the vagovagal reflex mechanisms, and we have the distension of the abdomen, either due to the post-laparoscopic reflux surgical procedures or discomfort in the chest due to GER or dyspepsia. On the other hand, the gastric belch is often due to swallowing, eating habits like rapid eating, use of carbonated beverages, or conditions that cause abdominal bloat and discomfort. Broadly, whether it is gastric belching or it is supragastric belching, both of them result in GER either due to esophageal distension or due to a reflux disease. Summarizing, the bloaters and belchers can be broadly classified under these four categories. The belchers, as I'd already mentioned, are either supragastric or gastric belchers, whereas the bloaters can be classified as gastric bloaters, which is usually due to gastroparesis or outlet obstruction. They can be due to constipation, when they're called as constipation-related bloaters, or intestinal, when it occurs 30 minutes after the feed. And therefore, these are the types of classifications that one can do in patients who have bloat symptoms. Switching gears to now hiccoughs, the last topic. This is a distinct entity which most often occasional. When it is multiple and prolonged, it is considered as pathological. It is referred as persistent when it occurs for more than 48 hours and intractable when it persists for more than a month. Hiccoughs are generated, unlike the bloat and the distension, it is generated by reflex arc. We have the afferents that is constituted by the vagus, phrenic, and the sympathetic nerves that is located between T6 and T12. The central mediating processes includes the upper spinal cord, C2 to C6, the brainstem, reticular formation, and hypothalamus. The efferent signals to the diaphragm and intercostal muscles is mediated by the phrenic nerve, causing involuntary spasm of the diaphragm and intercostal muscles, almost behaving like a myoclonus. Once the contraction begins, the hiccoughs occur at a rate of 4 to 60 per minute, depending on the individual and the trigger agent. In addition to this specific arc, there are specific neurotransmitters that regulate the reflex arc. They are the central mediators, which include the serotonin, the dopamine, and GABA, while the peripheral neurotransmitters are epinephrine, norepinephrine, acetylcholine, and histamine. So the take-home message between all these 4 or 5 criteria, the 4 of them seem to be interlinked, that is the belch, the bloaters, the aerophagics, and the belchers, whereas hiccoughs may be having a link with the other 4 components. Rome-4 criteria is a useful criteria to distinguish the various types of bloaters and patients with distension. Supragastric belchers should be classified as gastric and supragastric belchers. Supragastric belchers, as I said, is more of a behavioral disorder, and belch disorder, as I said, is quite distinct. And hiccoughs, unlike the other 4 which I mentioned, is actually a reflex-mediated phenomenon where the triggers actually stimulate the distal esophagus and stomach, and there can be an overlap with the other conditions resulting in bloat and distension. Thank you for your attention. Sit.
Thank you, ma'am. Now I would like to invite our next speaker, Dr. Gaurav Pandey, and the topic is Hyponatremia in Cirrhosis, Bedside Applicability of Algorithmic Management.
Sincere thanks to Professor Anil Arora and his team to giving me this opportunity. Sir had mentioned to keep it very clinical and whatever we do at the bedside. So I may not be presenting a lot of hardcore data. This would be the preamble of the talk. Coming to hyponatremia in cirrhosis, it's basically hyponatremia is sodium less than 135. It's an issue because the patient has hyponatremia. He can be predisposed to encephalopathy, has lower quality of life, risk of infection, predisposes to HRS because of the pathophysiology, and obviously has an impact on morbidity and mortality. It's pretty common, around 57 to 60% of patients may have this in clinical setting. So why does this happen? If you look at the overview of pathophysiology, cirrhosis causes portal hypertension. Portal hypertension will lead to gut congestion, splanchnic vasodilatation, gut congestion, leaky gut, increased bacterial translocation, production of nitric oxide, passing through the collaterals, causing systemic vasodilatation. So these people obviously have a lower blood pressure, lower MAP. This splanchnic and systemic vasodilatation leads to decreased effective arterial blood volume. So that is the crux, because kidney does not know volume is reduced because of what reasons. GFR is decreased, there is renal vasoconstriction, ascites formation, increased ascites leads to dilutional hyponatremia, refractory ascites and HRS. So it's basically a process in continuum that is initiated because of decreased effective arterial blood volume. That is the crux, decreased effective arterial blood volume. So it may not be same for all patients. As you know, clinically a patient can come with the albumin of 3 and sodium of 132 with large ascites, or he can have an albumin of 2.1 or 1.8 with a sodium of 118. So these people are drastically different, prognosis is different. But clinically, both of them have cirrhosis, hypoalbuminemia, and hyponatremia. So this effective arterial blood volume has to be assessed clinically. It may not be same for everybody. So the amount of correction may not be same for everybody. We cannot give 1 gram per kg of albumin or 12 mg of terlipressin to everybody. It has to be individual and case-based. The volume assessment is the crux. So what happens when there is decreased GFR? So once there is decreased GFR, there is increased water absorption from descending limb of loop of Henle. There is reduced fluid delivery to the descending limb of loop of Henle. DCT, there is more sodium chloride absorption, increased aldosterone secretion, increased ADH, and you have significant water absorption because of ADH. So this causes small volume, highly concentrated urine. So this happens whenever there is reduced GFR. It may be hypovolumic or hypervolumic, does not really matter. Okay. So coming to hyponatremia, clinical evaluation. Clinically, hyponatremia can be isotonic or hypertonic, but commonly we see hypotonic hyponatremia clinically that we'll be talking about. So hypotonic, assess the patient. He is dehydrated or edematous. So we'll not talk about isotonic or hypertonic. Dehydrated patient, hypovolumic, renal loss, extra-renal loss. All of us are very clear in that. So history here becomes very important. Patient is edematous. No or yes? If no, probably euvolemic, rule out SIADH, rule out renal and thyroid dysfunction. Patient is edematous, pedal edema, hydrothorax, cirrhosis, ascites, heart failure, nephrotic syndrome or CKD. So probably we'll be dealing with cirrhosis and ascites here. That's the point of context. So bedside evaluation, coming to history and examination, cirrhotics, history of infection, SBP, fever, GI loss, any fluid restriction, dose of diuretics that he has been on. Examination, look at the MAP and volume status. MAP with signs of ascites, volume status, hypo, hyper or euvolemia. All clinical signs have been mentioned. All of us are well aware of that. Signs of decompensation, how bad is the liver function, SBP or any other infection. So this is clear bedside evaluation that we come to gives us a rough idea of what type of hyponatremia are we dealing with. So algorithm to think, volume status, timing, how fast the sodium decreased or sodium was corrected, renal functions, precipitant, sepsis, ACLF, SBP. Endocrine and cortisol, thyroid, obviously we have to keep at the back of the mind. Review the bloods, rule out HRS, SBP, rate of fall of sodium. So hepatorenal syndrome, rate of fall of sodium and SBP. These are red flag signs. Have to carefully look and assess for these things when we look at the clinical evaluation. So clinical interpretation, hypervolumic hyponatremia. Clinical clues are ascites, volume overload, low urine sodium, chronic and gradual fall of sodium. Hypovolemic hyponatremia, obviously setting is over-aggressive diuresis, GI loss. Clinical clues are tachycardia, hypotension, dry mucosa. Lab clues are low urine sodium, high bun creatinine ratio. Treatment obviously is to volume expand and stop diuretics. Drug-induced, again a very common clinical setting. Terlipressin, one of the common drugs that we use. Patient has come with GI bleed, you gave terlipressin. The issue is there is an acute sodium drop. Temporarily correlates with starting of the drug. Other is hyponatremia, HRS, AKI, worsening of renal perfusion. There might be an acute insult. He might be having SBP, recurrent rapid rising creatinine, oliguria, large ascites, hydrothorax or pedal edema, low urine sodium. So look for the acute insult in presence of HRS, AKI here. If you, in clinical setting, we have terlipressin going on and patient may have HRS AKI. So how do you differentiate clinically? Hypervolemia versus terlipressin, a common clinical setting. Hypervolemia is gradual, chronic. Sodium level is reasonably stable, 120 to 130. And obviously, you have to give the therapy for that. Terlipressin, it's acute clinical setting, GI blood loss. It's relatively faster sodium decrease that is there. It is because of the terlipressin acting on the V2 receptor causing ADH release. So obviously here the rapidity and the clinical setting of GI bleed, or outside patient had HRS and was given terlipressin and then he has come to our hospital setting. So history becomes very important here. Less common causes are hypothyroid and adrenal dysfunction. One important thing that we do is to assess the volume on Doppler. That's one of the crux in our daily practice. We had an ultrasound in our hospital, in our actually ward till around 1 year back. Since 1 year we don't have that, but till that now we are doing with radiology assessment. We look at the IVC and RARI. These are very, very important things. IVC, small, collapsible or dilated, non-collapsible. And look at the renal artery resistive index. How big is the resistance to flow? Normally in hypovolemia, RARI is not very high. And you have hypervolemia, renal artery will be constricted because effective arterial blood volume still is less. You can look at the renal venous flow that is continuous or biphasic. Biphasic is basically because of the renal congestion that is there, causing resistance to the flow and making it biphasic. So this clinically helps us a lot to differentiate between hypo and hyper in confusing settings. Then clinical correlation has to be there and treatment is tapered accordingly. So if you look at the bedside algorithm, IVC diameter, IVC small collapsible, RARI low, monophasic flow, hypovolemic hyponatremia. It is IVC is dilated, non-collapsible, less than 50% collapsible, high RARI. Obviously goes towards more of a hypervolemic hyponatremia, going towards HRS, may require albumin 30%. So IVC and RARI, clinical algorithm, IVC small collapsible, RARI low or normal, hypovolemia or severe volume depression then when kidney vasoconstricts. IVC dilated, non-collapsible, normal, cirrhosis with ascites, not too bad a cirrhosis, should be easily corrected with albumin and diuretics. RARI increases, potentially AKI. RARI is very high, potentially going to ATN, or already ATN has set in with high creatinine. So simple IVC RARI, reasonable clinical clue for treatment. So treatment basically correct effective arterial blood volume. How do we correct that? It's albumin and vasoconstrictors. The volume has to improve. It's not about albumin. Vasoconstrictors also do the same thing. It's that terlipressin name is not important. What it does is flank-neck vasoconstriction. Causes vasoconstriction, increases the effective arterial blood volume. That has to be corrected. Albumin itself increases the sodium. Multiple studies are there on that. A very simple, elegant study in 88 showed that in hypervolemic hyponatremia, simply withdrawing beta blockers and diuretics did not improve the survival. The survival improved when the MAP was more than 82. Here, midodrine was added. So, oral drug that was added, MAP was increased, improved survival. Vaptens, commonly used for hyponatremia, studies have shown, this is an RCT of meta-analysis of RCTs, no short or long-term improvement with Vaptens alone. So, Vaptens obviously does not change the survival. Study by Professor Singh from PGI Chandigarh, combination therapy of tolvaptan plus midodrine actually had the best control of ascites, and tolvaptan alone was not as effective. So combination of vasoconstrictors, oral vasoconstrictor with tolvaptan helped improve survival. One of the studies published from our center, so 140 patients, high CTP hyponatremia, we gave midodrine and weekly albumin for over 18 months, and patients with the standard medical therapy with diuretics, patients, many of them were also on dapagliflozin who were diabetics. So patients with who mobilized ascites did very well, and people who mobilized ascites, majority of them had a MAP of more than 82. So get the MAP up, maybe by vasoconstrictors or albumin, and you'll get better survival in this subgroup of patients. Answer trial also did the same thing. Long-term albumin was there. Hypertonic saline recommended only when transplant is required or patient is extremely sick and symptomatic. Early tips, recent data from EASL suggests that they reviewed around 500 odd patients that ascites grade 3 with hyponatremia was the risk factor for decompensation over 1 year. So if you have a large ascites and hyponatremia, you have around 70% risk of decompensation over 1 year, and these people should be preferred for early tips. So large ascites, hyponatremia, go for early tips. So case scenario, there is no time to discuss the case scenario, but this was just clinical cases that we had for last couple of weeks. I'll just skip that. Approach to hyponatremia is basically volume assessment, clinical setting, and Doppler. This is a rough algorithm. Ultimately, it's albumin and vasoconstrictors increase the effective arterial blood volume. Rapidity of sodium correction. We all have a notion that you cannot correct between 6 to 8 millimoles per day. A simple study of more than 3,000 patients, multi-center observational study. They said that if you correct sodium, 38% had less than 6 milliequivalent correction. Their crux was 5 of the 7 patients who developed CPN had low rate of sodium correction. So this is still a thing to debate how fast to correct the sodium. Take home message again, it's clinical setting, volume status, labs and Doppler. That gives you a good clinical idea of how to go about the treatment. It's still a challenging issue, but obviously there is a good road ahead. Thank you.
Because of shortage of time, we would allow only one or two questions, and then we would proceed for all the speakers.
Question to Dr. Harshad, if you say. Yeah. Sir, most of our patients who are child C, they have an episode of hepatic encephalopathy, they have an episode of SPP, and then we probably put them on maybe on secondary prophylaxis for rifaximin. So in such patient, would you like to add on some other drug for the prophylaxis of SPP, or rifaximin is good enough to start with?
Rifaximin has been tried in small studies and shown to be effective. And as this Nature paper in October 2024 suggests, that in the Australian study, it produces RPO mutations to Enterococcus faecium, and that produces antibiotic resistance to daptomycin, done both in patients as well as in mice. I think you can use it, but then as long time as this study suggests, you're going to have some problem because it produces some mutations.
Should we use both things, Norflox as well as rifaximin, or just rifaximin alone is okay?
Because Norflox, as I mentioned to you, almost 80% of patients will not respond to Norflox because they are already resistant. So you have rifaximin, which is useful. As I said, it is useful. As small, some of them randomized studies have shown that it is useful. You can use it. But as I mentioned, we have to be careful because it's also going to produce certain kind of mutations when we use for a period of time.
And sir, and have you ever used primary prophylaxis for SPP in your clinical practice?
No.
Okay. Thank you.
You're talking about only prophylaxis, but for therapy, we know that SBP responds very well to the first shot even. So, do we require a lesser MIC for cure of SBP as compared to other infections?
Okay, you mean to say that we can give it only for a shorter duration time than for a longer duration?
A lesser dose, or probably the sensitivity may be more for SBP as compared to
the lesser dose. I'm not very sure, but then you can always give it less. For example, somebody who is an outpatient and develops it, you need not give it for a long period of time. You can give short doses. But somebody who's got, let's say, reversible liver disease like alcoholic hepatitis, again, you did not give them for a longer period of time. You can only give for a shorter period of time. But dose, I'm not really sure.
And will they be more effective as compared to other infections? Because SPP responds even to the first shot.
It responds to a first shot, but I have not seen a comparison between SBP and non-SBP with regard to short courses of antibiotics.
Just in response to Harshad's answer regarding the primary prophylaxis, I don't know how come he answered it that he never uses the primary prophylaxis. But a patient comes with a bleed, and almost everybody uses the antibiotic in that patient, and that is a primary prophylaxis.
I just want to let you know that the bleed, there is recently an Annals of Internal Medicine article, and it also carries an editorial, and it says time to stop, the editorial. And
I know, I've gone through that article.
Hang on, let me finish. And I'll. So basically, again, this has been going on for about 20-30 years, that you've been giving patients with antibiotics for bleeding. And most patients, if at all you have to give, it's probably only for a short period of time. So if you look at the article as well as the editorial, it says it really didn't make a difference whether you gave the antibiotics. It did not reduce chances of secondary bacterial peritonitis. It did not reduce outcome as well as complications. So whether you gave it for 0 days or 1 day, or whether you gave it for 5 days. So in other words, the question is still very open. And I don't use it, except that when patients come with GI bleed, they don't come to me first. They go to the ICU emergency, and they always give 1 antibiotics, and we stop at the rate of 1 or perhaps 2 injections of antibiotics.
So the audience should not go with the impression that GI bleed, don't use the antibiotic for the primary prophylaxis.
So what I'm saying that
is wrong.
If at all, if you have to give it, just give for just 1 or 2 doses.
They are giving for a short duration only.
You are giving, but I'm not giving, and all the editorial boards also say that we have to be a little more careful about it.
See, no, there is only one editorial, and this has been there for such a long time.
This was a systematic review as well as a meta-analysis which they conducted on thousands of patients.
So we can have this discussion during the tea time. I would like to thank all the chairpersons and the moderators, and we would invite for the next session.
For our next session, we would like to invite our moderators, Dr. Sujit Mainali, Dr. Premashish Kar, Dr. Ashish Sethi, Dr. Harsh Kapoor, Dr. Sumit Rungta. Our chairpersons, Dr. Swapnil Dhampalwar, Dr. Bhupendra Mahanta, Dr. Amitabh Sarma, Dr. Indra Kumar Jha. And we would like to invite our first speaker, Dr. Pankaj Puri, for his talk on fat and sucrose. Do they tango maliciously?
Morning, ladies and gentlemen, and thank you to Dr. Anil Arora and the Gangaram team for this annual conference, which is always an event which we look forward to. We have many people who come with obesity and they say, Doctor, I've hardly been eating anything and I've cut out all the fat from my diet and I still don't lose weight. And that's something we're going to talk about. Is there a role for carbohydrates, specifically sucrose and fructose? And how do the fat and sucrose dance together in the pathogenesis of MASH? If we look at the mechanisms of fat accumulation in the liver, you have increased free fatty acid uptake from the gut and from the adipose tissue. There can be increased de novo lipogenesis happening in the liver, a decrease in the fat transport in the form of VLDL, or a decreased free fatty acid beta oxidation. Basically, obesity and MASH is a result of excess of nutrients, which leads to these things and to insulin resistance. So logic suggests that increased fat should be the cause of fatty liver, and the consumption of high fat diet has been considered the primary driver of obesity. But more recently, there has been a focus on the detrimental effects of sugar as a contributor to obesity. Now, sucrose consists of two molecules, glucose and fructose, with a common bond in between. And probably it's the latter, fructose, which is the more important part in driving obesity. If you look at pathogenesis of MASH and the role of dietary fat and the role of sucrose. Dietary fat, especially saturated fats, increase the free fatty acid delivery to the liver. The impaired fatty acid oxidation and mitochondrial dysfunction causes lipotoxicity, which induces oxidative stress, ER stress, and inflammation of the hepatocytes. If you look at sucrose, sucrose drives de novo lipogenesis in the liver, and this leads to increased fat accumulation of the liver, oxidative stress. Now, besides de novo lipogenesis, there's a secondary role of the effect of fructose in the intestine, where it gets metabolized. It results in disruption of the tight junctions and endotoxemia and alterations in microbiome, both of which contribute to MAFLD. So this is data of overconsumption of sugar and the development of MAFLD. This was a systematic review on top, which is of 4,000 subjects, and resulted in, if people took excess of sugar sweetened beverages, which contain a lot of sucrose, fructose, this resulted in 53% increase of MSLD. Similarly, another study which showed a 40% increase in MFLD. Now, there is a dose dependent effect on this, depending on how much of these beverages they take. If you take less than 1 cup a week, a medium dose of 1 to 6 cups a week, and a high dose of almost daily of these sugar sweetened beverages, the result in increase in fatty liver is about 14, 26, and 50%. So if you're having a 1 cup a day, 50% you're going to land up with MAFLD. So this is the metabolism of sucrose, which contains of fructose and glucose. Both of them get metabolized. and the latter part of the pathway is common. But what we find is that there's a little difference in this part of the pathway where you have increased fructose related transcription, and I'm going to come and touch this later. But these result in formation of pyruvate, which goes into the TCA cycle and goes into the cytosol as citrate and is converted by de novo lipogenesis to fat. So one is what is happening in the liver. Besides what is happening in the liver, there is a second component of the gut related dysbiosis and increased translocation from the gut and of endotoxemia, which leads on to inflammation. So effect in the liver and effect in the gut both drive MASH. Now these are the differences in fructose and glucose metabolism. As I said, fructose and glucose are all part of sucrose. The basic difference is that in fructose there is no feedback inhibition. Now this lack of feedback inhibition in fructose results in drop in ATP and intracellular phosphate, which blocks protein synthesis and induces oxidative stress and mitochondrial dysfunction. So this is a basic difference between glucose and fructose metabolism, and that's why fructose is probably worse than glucose. Now, this was a study, a randomized controlled trial of overweight and obese patients who were randomized to receive glucose or fructose sweetened beverages for 10 weeks. Both of them gained 3 kilos of fat mass. But the difference was in fructose, the visceral adipose tissue was increased, while in glucose, the subcutaneous adipose tissue was increased. So the glucose and fructose favor differential adipose accumulation. The visceral issue happens with fructose. So finally we come down to what does it matter? Is it a high fat diet or a high sugar diet which causes MAFLD? I think there's no clear answer, and the truth lies somewhere in between. So we have dietary fat and dietary sugars, which are both going on to find fatty acids. The liver increase the liver fatty acids, which goes on to lipotoxicity and results in NASH formation. All fats are not the same, and the saturated fatty acids and the trans fatty acids have a negative effect on MFLD. On the other hand, omega-3 are good fatty acids. They have anti-inflammatory effect and they regulate lipid composition and improve insulin resistance, while omega-6 are worse, and the ratio of omega-3 and omega-6 is also important. So people with MFLD have less omega-3 and higher omega-6 omega-3 ratio. There's a standard statement that fat burns in the flame of carbohydrate, and sugar-free ketogenic diets stimulate a fasting-like state and rely on fat oxidation. So while high-fat diet induces obesity, you need a small amount of dietary sugar as a co-ingredient to turn off fatty acid oxidation and allow for full metabolic derangements to become evident. Now, the effect of fructose and metabolic dysfunction is also dependent similarly on high dietary intake. So this was a study in mice, and they found that there was a difference in fructose supplementation and glucose supplementation, and fructose consumption of a normal diet does not induce weight gain unless you have a higher percentage of fat. So most severe metabolic dysfunctions are induced by combined intake of fructose and high fat diet. So the high fat diet, as I said, it's well known that high fat and sugar free ketogenic diets promote decreased weight gain, and you need a combination of both fat and fructose in your diet to result in obesity. So to conclude, ladies and gentlemen, the effects of fructose and metabolic dysfunction are dependent on high dietary intake, and a high fat diet similarly requires a small amount of carbohydrate, sugar, to fully support the development of obesity related combinations, and they're synergistic and the promotion of hepatic steatosis. Thank you.
We would like to invite our next speaker, Dr. Anil Anand, for his talk on unholy alliance between heart and liver in MASLD.
It's always a pleasure to be in CHBD, and I'm grateful to Dr. Anil Arora, Dr. Ashish Kumar, and Dr. Praveen Sharma for giving me this opportunity. I have been asked to explore the emerging and rather troubling partnership, the unholy alliance between heart and liver in MASLD. And this is the brief outline of my talk. We'll walk through the heart-liver axis, its pathophysiological nexus in MASLD, its assessment, and finally consider treatment strategies that address both organs. My focus will be to summarize the most recent evidence and the contemporary thinking on the subject for the physicians in the audience. We all know that fatty liver disease nomenclature has been evolving over years as our understanding of this disease has improved. In 1990s, it was NAFLD, and we defined it as presence of fat in the liver in patients who did not take alcohol. In the COVID years, 2020, we changed it to metabolic dysfunction associated fatty liver disease, and it was defined on basis of presence of MAFLD, that is metabolic syndrome, diabetes in the patients who have fat in the liver. And the most recent change nomenclature to MASLD has been brought into focus, the cardiometabolic risk factors. That is the risk factors that lead to cardiac disease as well. So you will say that if cardiac metabolic risk factors are involved, the heart disease is going to be a problem in any case. The MASLD today is defined on basis of these metabolic risk factors, but these factors do confer a risk of cardiovascular disease. But what is important to realize is that the studies have shown that presence of MASLD multiplies this risk, which is over and above that conferred by the metabolic risk factors. And I'll give you some data to prove that. A meta-analysis of 11 million middle-aged individuals showed that the risk of new onset heart failure was 50% higher among patients who had MASLD as compared to those who had similar cardiometabolic risk factors but no MASLD. Similarly, a series of other meta-analyses involving a very large number of participants has clearly shown that cardiovascular risk of myocardial infarction, heart failure, arrhythmias are multiplied when MASLD is present as compared to when cardiometabolic risk factors exist without MASLD. This has given to the concept or the idea that MASLD is an independent risk factor and may be an important driver of cardiac events. As a result, more and more research is focusing today on cardiohepatic axis, or how heart and liver are interdependent and how they affect each other's health. Let us look at this relationship a little more closely. Importance of this axis can be gauged by two alarming facts. First, every third person in the world today has MASLD, and the incidence is rapidly rising. It is projected to reach 55% very soon, say in about another 10 years or so. And the second point is that population-based studies have shown that MASLD patients are dying at a very young productive age of 20 to 40 years due to cardiac events. A meta-analysis of 36 studies, including over 50 lakh participants, has shown that cardiac deaths are 5 times more common in MASLD than liver failure deaths. And the cardiovascular mortality includes patients dying of heart failure, arrhythmias, strokes, and myocardial infarction. It has also come to light that more severe the MASLD or fibrosis, higher is the risk of cardiac death. And I'll come back to this point a little later. Another very important facet that has come to light is that cardiac risk is higher among women with MASLD, and that MASLD seems to negate the traditional protection premenopausal women had against cardiovascular disease. So what is the pathophysiological nexus? We have detrimental pathophysiological mixes to explain the higher cardiac mortality, and there are shared risk factors in both diseases like leaky gut, insulin resistance, prothrombotic tendencies with endothelial dysfunction and oxidative stress, and there are some special drivers as well. Let me briefly touch upon just a few of them. Earlier this year, it has been shown that there may be shared genetic susceptibility, and many of the genetic variations that predispose to MASLD are causing lipid abnormalities that also accelerate atherosclerosis directly or indirectly. Insulin resistance is a well-known common factor that underlies MASLD, heart disease, diabetes mellitus, as well as obesity. Systemic inflammation is multiplied when more than one metabolic risk factors are present, and it leads to fibrosis in the liver and accelerated atherosclerosis in the cardiovascular system. Leaky gut and dysbiosis are common accompaniments of chronic inflammation and contribute significantly to it in MASLD. Apart from myocardial infarction, it also increases the risk of cardiac failure, stroke, CKD, chronic kidney disease, and cancers as well. MASLD also promotes endothelial dysfunction and oxidative stress, thereby accelerating the atherosclerotic process. Then there are large number of other pathophysiological changes that have been recently described to explain why MASLD seems to be driving the onset of cardiovascular disease, resulting in patients dying of cardiac events. Shortage of time will not permit me to go into details of these, but I am sure it is clear that MASLD leads to a series of proteomic and metabolomic modifications that are detrimental to cardiovascular health. The spectrum of heart disease in MASLD includes increased carotid artery intimal medial thickness, accelerated atherosclerosis, cardiac remodeling, myocardial infarction, arrhythmias, especially atrial fibrillation, increased epicardial fat, and heart failure with preserved ejection fraction, something very similar to cirrhotic cardiomyopathy. So, as a physician or a hepatologist, what assessment should be done? EASL has simplified the plan for you and just do FIB4 and some imaging assessment sequentially. Today, cardiology journals are full of correlation between FIB4 score and the cardiac events, as is evident from this paper, which is one of the many which have been published in last 2 years. Higher the FIB4 score, higher is the risk of cardiovascular disease. FIB4 can be sequentially followed by elastography of liver, and that too can stratify the cardiac risk. Patients with no fibrosis have relatively higher risk than the normal population of cardiovascular disease. But as compared to that, when the elastography shows high fibrosis, the risk of cardiovascular disease is several folds increased. Hepatic steatosis can be has a strong correlation described with coronary artery calcium scores as well as carotid artery intimal thickening. Both are indicators of cardiovascular risk. This brings us to the question that what should we do in this situation? 3-step simple approach outlined here is recommended. Step 1 is lifestyle modification, which will benefit both the liver disease as well as cardiovascular disease. 7 to 10% weight loss achieved through lifestyle changes or use of newer drugs or even bariatric surgery will help improve in both diseases. Step 2 is pharmacotherapy, which was touched upon by Dr. Wim yesterday. This chart summarizes the type of treatments available, and it classifies them if it will benefit cardiovascular risk, MASH, or fibrosis. You will notice that in addition to lifestyle modification, 2 of the most popular drugs, that is resimetrome and GLP-1 receptor antagonists, are beneficial on all counts. This diagram summarizes the integrated approach in patients being recommended earlier this year at various stages of MASLD. And I will briefly highlight 2 wonder drugs that have come when the MASH or fibrosis is present. Resmetirom was approved by FDA in April 2024 and represents the first specific treatment of MASH with moderate to advanced fibrosis. Beyond liver benefits, resmetirom demonstrates favorable cardiovascular effects, including LDL cholesterol reduction, though long-term cardiovascular outcomes remain under investigation through the ongoing Mestre trials. GLP-1 receptor antagonist, particularly semaglutide, shows promise both for MASLD and cardiovascular risk reduction. These agents address both metabolic dysfunction and provide proven cardiovascular mortality benefit in high-risk patients. Last year, American Heart Association statement recommended that all MSLD patients should be screened for cardiovascular disease regardless of established atherosclerotic risk factors. And I found this chart very illustrative of how our understanding of this unholy alliance has evolved over years. We recognize that fatty liver is the risk factor for cardiovascular disease almost a decade back. Over the next few years, we realized that it is an independent risk factor apart from the metabolic syndrome that itself is a risk factor. Last year, cardiologists have started advising screening all MASLD patients for cardiovascular disease. And by next year or so, I'm sure there will be a call to treat all MSD patients to prevent cardiovascular disease. To summarize, ladies and gentlemen, I'd like to say that we should screen all MSLD patients for cardiovascular risk factors annually, utilize FIB4 as both liver fibrosis and cardiovascular risk marker. Patients with FIB4 more than 2.67 require intensive cardiovascular risk management. Consider cardiology referral for patients with advanced fibrosis or multiple metabolic risk factors. Young adults with MASLD need early cardiovascular intervention. Women with MASLD may have higher relative cardiovascular risk than men as they lose hormonal advantage due to MASL. Emphasize lifestyle intervention for dual liver and cardiovascular benefits. Focus on emerging therapies with potential cardiovascular benefit such as resmetirom and GLP-1 receptor antagonist. Thank you very much for your patience.
Thank you, sir. So due to shortage of time, we will allow only one question from each speaker.
Okay. I have a question for Dr. Puri. Did you come across any association between sucrose and leptin? I didn't see mention of that in your talk.
Say I haven't come across any talk on that. If you're aware, I'd like to know.
Okay, I'll probably comment on that. Leptin is a hormone which is produced. It's for satiety. And when you take a lot of sucrose, the receptors are disarranged and the satiety center is disturbed. That's another factor which will increase the intake and probably would cause more fat and carbohydrates and sugar intake. That has been associated here.
Sir, I know that is well documented pathogenesis, but I haven't looked at any recent study or any study which has looked and quantified these levels. If you have, that'll be nice.
Sir, one minute. Sir, question for you. Sir, we always advise them to have a lot of fruits. Cardiovascular patients. Yes. Fruits contain fructose only.
Very true.
So, according to this, fruit should be avoided?
No, there are studies which show that fruit are safe, and if fructose from fruit does not cause liver disease. Right. And the part of the reason for that is fruit contains lesser amount of fructose than you would in, say, sugar drinks. Secondly, fruits contain fibers and they contain antioxidants, and that's why liver disease doesn't happen.
This is a question for Dr. Anand, sir. Dr. Anand?
Dr. Anand, sir. आपके लिए.
Okay. Sir, 1/3 of the Indians, they have MASL, which include both the children as well as the adults. Which minimum test would you advise to screen for cardiovascular risk factors in all these subgroups? Maybe the children which are less than 20 years, from 20 to 50 years, more than 50 years. Is there any particular subset of tests which you would recommend?
First test I said is FIB4, which can easily be done. And then assessment of all the metabolic risk factors, cardiometabolic risk factors, that is presence of hypertension, dyslipidemia, obesity or abdominal obesity.
I would like to get the test for the heart assessment.
Heart, the usual tests that are required in adults are coronary artery calcium scores can be done, and carotid artery intimal medial thickness. These are non-invasive
My worry is
tests.
because most of the, even the children, they are also having fatty liver. And they are maybe less than 15 years, some are between less than 25 years or maybe 20 years. Would you require the same type of test for everybody?
If there is no fibrosis and the cardiometabolic risk factors are less than 2, then they don't require a separate cardiovascular assessment. Okay. If there is a fibrosis and the cardiometabolic risk factors are more than 2, they need a proper cardiovascular assessment.
I've been asked to inform that due to paucity of time, we'll close this session now. Thank you very much.
Thank you, everyone.